I'd like to now invite Dr. Mylaine Breton to deliver her presentation, tell us about the different healthcare models in Quebec. Mylaine Breton is an associate professor in the Department of Social Science and Medicine at the University of Sherbrooke. She holds a Canadian Research Chair in Clinical Governance on Primary Healthcare. She received the 2019-2020 Canadian Harkness Fellow. Her research program consists of applied research projects undertaken in partnership with clinicians and managers to improve the organization of healthcare. Her current research focuses on primary healthcare, and she focuses on better understanding promising organizational innovations in order to improve accessibility and continuity of service. These are words that we often hear. Her presentation is going to be in French only, but it's going to be translated after the meeting and also simultaneously right now. Please be careful about the elements that she mentions, because we're going to get back to that at 4 o'clock. Yeah, at 4 o'clock. Hello, everyone. Thank you for your presence, because this week the weather is very nice. So thank you for your generosity given the nice weather. It's very simple today. I'm going to tell you about the different models, what is being done around the world and that could inspire us and that could also adapt to Quebec. What is the Quebec model? And what is done elsewhere in the world. So we're going to have a look at what is being done around the world in this respect. All right. So first of all, the organization of primary care is very important. It's a very important value for Quebecers, for Canadians in general as well. It's a mediatic issue. It is very highly politicized as well. I mean, it is politically charged. It's very important to be able to access healthcare when we need it. So this is very important for Quebecers. It is an important value. So two things. First of all, I'd like to put things into context. What is primary care in Quebec and in Canada if we compare it to the rest of the world in terms of funding, for example, and other aspects? And then we're going to have a look together at what is being done elsewhere. So first, the funding of healthcare. You know, the investment in health. It's a provincial funding, but it's a very important part of our budget in Quebec. And if we have a look at healthcare, we have 5% of the budget that's invested towards primary healthcare. We're talking about family doctors, frontline workers, health workers. So this is an average of 8% that we invest. So we invest less than our total budget, and the budget for health is very important. It's 50% of our provincial budget. So we're talking about the provincial jurisdiction for healthcare. So it is transferred from federal level, but each province have their own priorities, models, and choices. So we can see differences with BC, with Ontario. We have similar problems and situations sometimes. Primary care, we invest less in Quebec or in Canada than in the rest of the world. Then another interesting issue, do we have the same quantity of doctors than in the rest of the world? We talk about family doctors. It's always hard to find enough doctors. What we can see, if we compare with the rest of the world, we can see that we have less family doctors per capita, so that's an issue. And also to have a look at what is the model that we have. And we saw that during COVID, we had... we saw that in the rest of the world, there were countries with more doctors or more family doctors proportionally to the population. And if we have a look now at the offer of primary care doctors in the other countries, how many doctors on average can we see in province? We can see that in Quebec, we see less patients. Doctors see less patients per week if we compare it to the rest of the provinces in Canada. And now we work less, but we work elsewhere. And family doctors in Quebec work a lot in terms of hour, but they see less patients because they spend a lot of their time elsewhere in hospital care or in long-term care. So in Quebec, if we compare our situation with the rest of Canada, in Quebec, doctors see less patients if we compare it to other provinces, and if we compare it to the rest of the world, if we compare to England or France or Sweden, those doctors see more patients per week than it is the case in Canada. So doctors in Canada, we always tend to say that there are less family doctors than elsewhere, but we made different strategic choices in Quebec. We have done that for 20 years now, some special medical activities to the doctors. We ask them to cover hours, work them in ER. So we force doctors to work elsewhere and not have an exclusive practice, and that's what explains this difference. If I work 45 hours and I spend 15 hours out of these 45 at the hospital, obviously I will have less time to devote to my patients. So this is also the notion of accessibility, continuity within the organizations. This might be an explanation that explains why family doctors spend less time with their patients in Canada and in Quebec even. And also, for example, sport medicine, emergency, or following up on a pregnancy. So this is another interesting piece of information. And then we also talked, and we will still, about a very important feature of health system. Are you affiliated to a medical team? Do you have a doctor, a regular doctor that you always see, that knows you, or do you have a family doctor even? So are you in touch with a doctor that knows you? So do you have this notion of continuity in terms of care? In some countries, everybody has a family doctor, or every citizen is affiliated to a clinic or to even a doctor that knows them personally, and that follows up on them. So there's this long-term relationship. In Canada, it's not the case at all, and we are really not in a good situation if we compare ourselves to some other countries in the rest of the world. In Canada, we score really low on this regular doctor score and continuous care. We are in Canada, we are already among the worst in the world, and in Quebec, we are also among the worst in Canada. So just to show you that we don't score very high in terms of regular doctor, and that has to do with the relationship. And this data, this survey is being done every 4 years, and our results have even gotten worse, than what they were earlier. What's important as well is to have a look that who in the population generally does not have family doctor. If you have a look among the population, those people who don't have a family doctor are some groups of the population, or some groups of the population that have less income, less level of education. They are more likely not to have a family doctor. So we observe really this gradient of inequality also regarding the access to a family doctor. So I was telling you that we are not really good in Quebec if we compare to the rest of Canada. In Canada, we say that 75% have a family doctor, but this is a very important Canadian problem. So it's really a global problem that we can see everywhere in Canada. Some countries have a good score, like some other countries like England or like Portugal. They have a very high score in terms of family doctor affiliation. So 60% of Canadians say that accessibility is good, but to have continuity, it's really good. Do you have a doctor that knows you? We often talk about the family doctor or the practitioner, nurse. Do you have a particular relationship with a healthcare professional that knows you and that you can see on a regular basis? So these are the data globally. Not so much investment. We have less family doctor. And we have family doctors that work elsewhere that might explain the reason why they see less patients, because they have less time available to actually see their patients. And that's also due to the system. So some family doctors are asked to spend time elsewhere doing other tasks. I'd like to now tell you what is being done elsewhere in the world. Now, Mr. Legault, the Prime Minister, said that this is very important. How can you find a practitioner nurse or a family doctor? What's important is to really have this relationship with the healthcare professional that follows up on you, or at least to have some continuity, a regular source of healthcare. There are modalities in some countries where automatically you are registered to a clinic that is close to your home. That's the case in Finland, for instance. In Norway also, you have a mechanism that allows you to have a family doctor. And patients, if they wish, can change once a year. So no matter the reason, you are allowed to change family doctors. And in some other clinic, some doctors have to take on patients in the neighborhood. So it is really a system where everybody has a family doctor, and these are formal mechanisms that allow you to have access to a family doctor. And we can see a parallel with the school system in Quebec. When you move to another neighborhood, it's not up to the parents to find a school and ask them if they can take on your child. It is automatically done since you joined the new neighborhood. So it is maybe the comparison that I can show you to explain how it works in terms of healthcare in some other countries. It's not up to the patient, or not the responsibility of the patient, to go and find a family doctor, but it is being done kind of automatically depending on the neighborhood they live in. And in Quebec or Canada also, we have sometimes the problem to find a family doctor. We implemented centralized waiting list. We talked to you about automatic access. So this is a centralized waiting list. And this is implemented in 8 provinces in Canada. So we all have the same problem. We need a similar strategy for that. And even in Quebec, we are even more sophisticated in this access. We establish a list of priority depending on the different categories of patients that goes from most urgent to less urgent, so that you can have access to a doctor. And in Manitoba, it's a different strategy. But you have to keep in mind that it's the patient that has to register based on their geographical position, based on their postal code. And that's how they access to a family doctor. And for those that have tried these access to a family doctor, you have to be patient.
So since 2009, this mechanism of Quebec Family Doctor Finder allowed 1.5 million patients to be registered with a family doctor. And recently they tried to modify it. So this was an election, it was a campaign promise, and recently 500,000 patients have been registered collectively. So patients were registered to medical clinics, and that clinic took 1,000 new patients. So the patient cannot call directly the clinic, but if they call the the access point, the primary care access point, they can be sent to that clinic. So this gives no direct service to the patients. And if you read the news, we say this year family doctors have 500,000 new patients. However, these are not directly registered with the medical professionals because the patient cannot call the clinic directly. So this was a financial incentive to have this collective registration. Then we have a third category, which are orphaned patients. They are not registered to the Quebec Family Doctor Finder, and they are not registered with any family doctor or nurse practitioners. And these are 630,000 people. So these are three categories of services. So if a patient is registered at the Quebec Family Doctor Finder, they might have more chances to find a family doctor. And the waiting periods are very long in Montreal and in Gaspésie. Compared to Gaspésie, we have disparity. We wait 600 more days in Quebec. So this primary care access point does not exist everywhere in Canada. In Quebec, we are the access point that has the longest waiting list. Sometimes patients have to wait 2 to 4 years before they get a family doctor. So in the meantime, we put into place a primary care access point. And once again, here there are many disparities between Quebec and other areas. So here the idea is that we can find medical appointments for people who really need it with a priority algorithm. So 60% of the needs will be directed to a medical clinic, and 40% of appointments will be directed to another professional. So the goal here is to redirect the patients to the right people. However, the modalities are not well developed for that orientation to be adequately made. But this is the Quebec model for now for orphan patients who can get through this primary care access point to get a medical appointment. And the government invested a lot of money to have this primary care access point. And there are financial incentives for family doctors. For example, a patient from primary care access point gets more money to the doctor than a regular patient. So this is the structure that exists in Quebec. So I told you it is important to have a medical doctor or a nurse practitioner. We develop different mechanisms. Some are more collective and structured according to the neighborhood. In our neighborhood, we have a waiting list. However, the waiting list, the duration of the wait is very long. We have 80% of Quebecers who are registered to a family doctor. So are registered with a family doctor. So this is a good thing. And once you are registered with a family doctor, then you can access other services. However, if you're not, the only alternative is the emergency room, because medical clinics only accept patients who are registered to the Quebec Family Doctor Finder. So once you're registered with a family doctor, and this registration has been formalized. This is not the case with other provinces, but in Quebec, you need to be registered in order to get access to other services. Often patients are registered to a group of family doctors, and they also have access to nurses, nurse practitioners. So different services are offered according to the number of patients registered with the the medical clinic. So in Quebec, we developed that link and we formalized that link with a family doctor. It is a formal registration. We start to do that with nurse practitioners, frontline nurse, primary care nurse practitioners. There are a few of them. So it's not only the family doctor now who acts as a mentor for patients. Other provinces were ahead of Quebec in this area. So now we have more and more nurse practitioners too. So the professional source of care or affiliation, patients are either registered with a family doctor or a nurse practitioner. 65% of the patients are registered with family doctor groups. And 23% of patients are orphan. They have no family doctor nor nurse practitioner. I told you a bit about the collective registration. It's a bit complex, but it is an important issue. It is a political measure that has been implemented in Quebec right now. So maybe now something that we do well. I told you a lot about the issues in Quebec. However, we also do some things well. We have an interprofessional team that is very well developed in Quebec. In France, the midwife is part of primary care models. There are some countries where the primary contact, like in Finland, where the primary contact is a nurse. She does the follow-up, the infant well-being care. So even France is not very developed regarding interprofessional teams. They have some interprofessional clinics. However, in Quebec, we are ahead of other countries in this area. And in Quebec, we are pioneers within that model. We have one main model with some variations. However, since 2012, we have family doctor groups. And within these groups, we have family doctors, nurses, social workers, pharmacists. And so we have this team, which is developed even more. It is our model. We have 340 teams, and 65% of Quebec patients are registered with those family doctor groups. These are public resources that are added sometimes to private medical clinics, and nurses, social workers are public workers that work within those private clinics or within local community service centers. So we were the model in the world. We were the pioneers of that model, interdisciplinary teams. People came to see our model and study it. And on paper, it is one of the most beautiful models. However, doctors did not adhere to this model, so we had to rethink it, which is the multidisciplinary model with private governance. So here, doctors can be owners of the clinic, and with the fee-for-service model. So social workers and nurses are more integrated in clinics in Ontario too. However, Quebec has a stronger model. Regarding British Columbia, they're trying to think how to integrate nurses in their practice. So in Quebec, as I mentioned, we are pioneers in that model. Psychologists are rarely integrated in those teams. So we should think about what other professions we could add to those teams. So I talked about this affiliation with interdisciplinary teams. So do we have a structured alternatives? For example, if someone wants an appointment in the primary care outside of the emergency model. Throughout the world, there is a very interesting model. It's Norway. There they have a regional and structured model that redirects patients in a very appropriate way. As a patient, you have no right to go to the emergency room. So that's a law in Norway. There is a nurse who will direct the patient and tell them if they have to go to the emergency or not. So they have a prioritization algorithm that are regional, and they will redirect the patients that way. In Finland, they have clinics that are integrated in emergency centers. So we talk a lot about redirecting patients at the right moment, to the right place. So is there a way to go to have a structured network? We have health info, and it is they offer no service, but they will redirect the patients to the right professional. So we have no regional or provincial coordination. So different family doctor groups may coordinate amongst each other, and this varies according to their to the number of patients they have. I remember in Grand Bay there were 4 clinics. One would open on Monday and one on Friday, so there were less services. So it was not weighted according to the population. Then we have a network clinic that is open all year round. And then we have other models, and they have some agreements, and there it really varies according to the area. And these are walk-in clinics. It was said that these walk-in clinics would only give appointments only give access, to people who are registered. So that was an issue. And today we are forcing all walk-in clinics to give access to orphan patients, those who have no medical doctor or nurse practitioners, as well as those who are registered with those walk-in clinics. And so those clinics are asked for additional resources. And so the network clinics are forced to open all year round. So this is how we try to offer services throughout the provinces. So I go and see my family doctor for follow-ups, but when I have an emergency, I never go to the family doctor. So this So are you able to see your family doctor or your nurse practitioner on the same day when there is an emergency? And what we see around the world, that 60% of those countries may be able to offer those services. And we see that Canada, we are amongst the worst. I think in 2016, we were at 43%. So only around 40% of the clinics answer that they can offer appointments within 2 days. However, if there is an emergency and we cannot meet the clinic or the family doctor, the patients have to go to the emergency room or somewhere else, and we lose that continuity of care. And in Quebec, if there is an emergency, we see the same statistics compared to other provinces. So we are all very bad in this area. And then we talk more and more throughout Quebec and other provinces with information technologies. How do we use those information technologies in primary care? When I did my PhD in 2009 in a medical clinic, I asked them if they had a digital a file, if they had a digital record. And so over time, clinics have modernized and turned to the digital health records. However, we want to also use technology to book appointments. For example, there are safe chats like in the Netherlands. So according to the patient's characteristics, it's also possible to recommend follow-up appointments. So this does not exist yet in Quebec. However, we could add those features to the digital health record. And you talked a lot about the data. Do patients have access to their own health data? This is an issue throughout the world. There are countries that are in advance. They have electronic systems for appointment bookings. In Quebec, if we do the study, maybe we would be well ranked. So we asked the question, are you able to book an appointment online? I think it's approximately 22% in Canada. In France, it's 30%. And then is it possible to communicate with your family doctor throughout securized apps? Canada is at 23%. And Quebec is at 12%. Is everything all right? No, I think you will have to end soon. Oh yeah, this is my conclusion. So perfect. So very quickly, I have 4 minutes. So here are the main characteristics. Affiliation with a professional versus affiliation with a primary care organization. Yeah, so we should think about it. Is it important to be inside of an organization or to be with one professional? So here the issue is the continuity of care. So if there are not enough family doctors, should we turn towards those or group doctors? Then do we want to automatize the registrations when we move to another neighborhood? And then a rapid access to primary care with a professional that knows the patients. And how can we better manage the schedules so that we can always have an appointment with a family doctor, not only for follow-ups, but also if there is an emergency. Then the interprofessional team, we are already doing good in this area, but maybe we could think about how we could add other professions like a psychotherapist. And then last thing to keep in mind, what's the place of information technologies for appointment booking, communication, and access to the health record?